Good morning, everyone.
Good morning.
Can everybody hear me okay?
Yes.
Great. Well, my name is Mary Bradley, and I am the Director for Healthcare Services here at Army Residence Community. I'd like to welcome you today to Director's Dialogue to talk about healthcare, and it is a big subject, so we're going to try to stay focused on point for you today. We do not have slides for presentation, but we do have handouts, so I appreciate Aaron's help and Cindy and Ms. Taylor passing those out for us. You should have one of each. One is a list of our key speakers that you're going to have today for healthcare. The others are a 5-star rating page from the Centers for Medicare and Medicaid Services from CMS. The other one is a handout we did before about the differences key between skilled nursing and assisted living. That was popular. A lot of people still have questions about that, so we made some more copies of that for you today. And also some cards for our marketing counselor for assisted living, Diana DeLeon. So in case you have specific questions on AL, she'll be able to address those for you. So does everybody have copies, or if you still need copies, raise your hand. It's good to have those. Got some hands up, so Aaron and Cindy are going to help us get those to you. Appreciate that. So first off, I wanted to do just some general introductions, face with the name. And I really want to start by saying a big thank you to Debbie Hargett and Resident Services. Where's Debbie Hargett? Stand up, Debbie Hargett. Thank you, Debbie. Healthcare depends a lot on resident services and that collaboration, making sure we're all working in sync to address all of our residents' needs as we move along through the continuum of care. So thank you, Debbie and team. Appreciate that very much. I want to now put some faces with names to our speakers that we are going to have today. First, we want to have Faye McGee, our Director of Nursing, stand up and wave, Faye. Faye. We have Diana Lorenzo, our Admissions Liaison for Healthcare. We have Enrique De Luna, our Assistant Director of Nursing. And last, we have Deborah Settles, a lot of Debbies. Deborah Settles, our social worker, very key with us today. Thank you. Okay, so first we're going to start off with a little bit more about myself. I do have over 20 years of experience in healthcare, working with CCRC communities, mostly in Texas here. I am a licensed master social worker and administrator. I have worked with Air Force Village, which is now Blue Skies of Texas, about 12 years as administrator. Patriot Heights in the Medical Center for about 7 years. Eden Hill Communities in New Braunfels, 2 years. And now here at the ARC, about 6 months. I do prefer working with nonprofit communities because they're usually faith-based, very much about service and quality. Not that for-profits are not about that, but you do get more of a special consideration and a real, a more personable approach and a more caring sense when you're working with nonprofits and CCRC. So I was very impressed to join the Army Residence Community because there's a lot of like-minded folks that are about quality, right? Patient care and quality is so important, and I'm very glad to be a part of that. Some of my key influences over my lifetime, mostly spent a lot of time with my grandparents, and they were a big influence on me. Listening to their stories and valuing their dedication and service to what they've done in their lifetime. One of my grandfathers was president of Studer's Photography Company in San Antonio, and my father also a psychiatrist, still practicing a bit, and established a good work ethic in me. So I've just been raised and working with seniors and value their input, and a lot of good life experiences and stories to share, which are so important. And really wanting to teach our folks in healthcare to pay attention and listen, right? Listening sometimes is a hard thing to do. Everybody wants to talk and to be heard, but listening is so key. So we really try to teach our folks to listen up, lift people up, and to follow up, right? Make sure that you follow up on what you're going to do and what you're going to say. Very important. So I wanted to share with you today some key highlights about healthcare and assisted living. As you may have heard, both of our assisted livings with Crestway and Lakeside had deficiency-free surveys for 2024, so round of applause for that. That's very important with Health and Human Services. And again, we do have those handouts for you about the differences of assisted living and skilled nursing, and Diana DeLeon's cards if you have specific questions about assisted living. Today we want to focus primarily, for time's sake, about how to have a smooth admissions process, admissions through discharge, when you're focusing on healthcare. So that's why I've asked some of our key speakers here today to talk to you about that. I want to highlight for you the page that you were given that has all of our key contacts for our speakers today. And also, if you'll look at the page now about our overall scores for 5-star for Centers for Medicare and Medicaid Services. On that handout, it's important to let you know that those scores are updated monthly. They're on the Medicare.gov website. If you go under Care Compare, you can locate that information. You just simply type in the zip code or the address, and then Army residents will come up, as well as some of our competitors in the community, and you will see how we rank amongst those folks right now. The calculations for how that 5-star rating is complicated, but it's made up of 3 key areas. You know, the first area on there that you'll see has to do with your health inspection score. That health inspection score is weighted on an average of 3 of your last healthcare surveys, and those happen annually. We're right in the window right now for ours, sometime between now and the end of May. But your most recent survey carries the most weight, and you can see that right now we are 4-star rated, no pressure. But that has to do a lot with day-to-day constant evaluations of everything from food service to the environment to nursing care to the cleanliness of the building. We're constantly auditing and monitoring our quality assurance processes to be ready every day for inspection. The second item on there that they evaluate is our quality measures, what also are known as QMs. And that covers everything from bathing and dressing to grooming, looking at your frequency of falls, trying to keep that down, looking at your infections, trying to minimize or keep those down. Things like wound care, of course we don't want to have issues with that, and we do not. Things like weight loss, you know, trying to make sure that we're maximizing people's quality of life for as long as they can at their strongest level possible. And again, that's a daily audit by nursing and all departments to keep that at a high level. So if you'll look at our quality measures, we are 5-star right now, and we are doing our best to stay that way. The third part of that is the staffing calculation. Now, we're proud to say at Army residents, again, because we're focused on quality, we do staff higher than the national and state averages. When you look at our measures under that category on the website, that takes into account things like, do you have your 8 hours a day of RN coverage? We have higher amounts and percentages of RN coverage in healthcare than most nursing facilities. So I think that deserves a round of applause right there. Quality, outstanding. Let's see here. It's very important that, you know, in order to maintain these things, we look at things such as quality assurance. Quality assurance is a process that healthcare is involved in that meets on a monthly basis. You probably have heard quality assurance performance improvement. For healthcare, that involves our medical director, Dr. Victor Soria. It involves our director of nursing and the key folks that you see up here and several department heads. On a monthly basis, we meet to review those areas that I mentioned. Things like wound care, skin care, falls, infections, trying to again make sure that we're auditing and minimizing issues with that process. There's so much that we could talk about with healthcare, but to keep this succinct and allow time for question and answer, I really want to focus again on what makes admission through discharge a smooth process, and how can we ask all of you to help us to make that smoother for you. So we're going to start that by having our Director of Nursing, Faye Mungian, to come up and talk to you about some of the situations of why people come to healthcare and need that. So over to Ms. Faye.
My name is Faye again. I'm the Director of Nursing and Healthcare. Can you hear me?
Yeah, that's good.
I've been in long-term care since 2009 and have served as a DON since 2013. And 3 years of those years are with the ARC. I started here in October 2021. The last facility I worked with was across the street, which is Meridian Care Center. It's chronically acute facility that takes care of chronically acute residents specializing in respiratory failure. They're mostly ventilator-dependent residents. A few years ago, I had the pleasure of taking care of a couple of ARC residents. They were admitted there. I think his spouse is even in the crowd right now. I joined the ARC mainly because of its excellent benefits and convenient location, for which I am very grateful. I'm taking care of a 94-year-old mother, so I have to live close by. The organization provides strong support for the employees, and I've personally received great encouragement from my superiors, including Steve, HR Stephanie, and Debbie, Debbie, who is a key advocate for healthcare. Thank God for that. Additionally, several committees are dedicated to improving healthcare in meaningful ways. Most of the residents I have encountered are very respectful and well-educated and incredibly supportive. They have a deep understanding of the challenges in healthcare, which I truly appreciate. So far, this has been the best workplace for me. Thank you. Okay, my task to talk about today is admission to healthcare. Okay. There are I'm going to talk about the 3 common situations that you may find yourself needing to stay in healthcare. One is what we call a respite care. Respite care is temporary. It is when you're still living independently but rely on a loved one or caregiver for assistance in your daily care. If your caregiver becomes unwell and is temporarily unable to provide necessary care, you may need short-term placement in healthcare until your caregiver recovers. The term for that we use is the respite care. Okay. So before you come to healthcare, we will need a list of medications you're taking and maybe the most recent, history and physical from your doctor, so we would have an idea on how to care for you. Although resident services, again, are very helpful in assisting us with obtaining those, like they give us the medication list and even bringing your medications to us. But please note that when you're transitioned to healthcare, we will need the medications in their original blister packs or bottles to ensure we can accurately follow the doctor's orders. The second situation that I would want to talk about is long-term care stay. This situation arises when you can no longer live independently, safely at home, and require a higher level of care to meet your daily needs. While the admission process is like respite care, this type of stay is intended for long-term care rather than being temporary. Okay. Another situation occurs when there is a change in your health condition that requires hospitalization. While after your hospital stay, you may need rehabilitation to help restore your prior level of function and temporarily support your recovery so you can get back to living independently. So that's the third one. Now, let's talk about what happens when you're admitted to the hospital for any reason. And more specifically, how you can utilize your Medicare and TRICARE benefits. Because that's the goal. When you come to healthcare, we would like to utilize your Medicare or your TRICARE. To qualify for Medicare coverage, you must have a hospital stay of at least 3 midnights. If you're admitted for only 1 or 2 midnights, Medicare will not provide coverage. So 3 midnights is the key. I'm sorry, can you hear me? Yeah, 3 midnights is the key. And I know majority of our residents they don't like to stay in the hospital. They would like to come to healthcare as soon as possible. But unfortunately, Medicare will not cover your stay, will not cover the rehab and medications and all, and the board and whatever that you need expenses when you get to healthcare. So that's very important to note. Okay, 3 midnights at least. If you have also, that is when you have a traditional Medicare. If you have a Medicare Advantage through providers like Blue Cross Blue Shield or Humana or WellMed, your coverage is managed differently than traditional Medicare. Before you go to healthcare, we must first obtain what we call a prior authorization from your insurance provider. Without this approval or prior authorization, your insurance may not cover the cost of your stay on healthcare. But I want to point out something. This does not mean you cannot come to healthcare. It simply means we must obtain prior authorization from your insurance providers. The specific of your coverage, such as the amount covered, the percentage paid, and the number of days included, are determined by your insurance company. Okay, this is when you have that managed care. The traditional managed care are different. Okay, so when you enter a healthcare facility like ours, whether it's temporary, long-term, or from a hospital transfer, CMS mandate completion of several paperwork. Beyond paperwork, CMS also requires completion of several assessments. And I could tell you later the list of the assessments that we have to do to comply with the regulation. My role as the director of nursing is to ensure, timely completion of assessments within CMS guidelines, accuracy and documentation to avoid Medicare penalties, involvement obviously with interdisciplinary team, and of course, most importantly, staff education to meet with compliance with evolving CMS regulations. Healthcare facilities operates under strict CMS regulations, which involve extensive oversight and require us to complete and submit numerous assessments to meet compliance. Therefore, they visit our facility annually to ensure we remain in compliance, meet all the deadlines, and then they can recertify us to operate as healthcare provider for another year. So I'm really kind of nervous now because we are in the window and anytime they could walk into our facility, and they stay for about a week, making sure we're doing what we're supposed to do. Thank you.
Good morning, everybody. I'm Diana Lorenzo. I've been at the ARC for about 8 years. I started off at the main dining room. Then I went over to security. I was in the Kiwanis Scholarship. I graduated with my associate's degree, and I transitioned off to healthcare as the office healthcare assistant. I am now doing admissions. So my job is to work with resident services, get a list of all the residents that are in the hospital. Once you're in the hospital, regardless if you've been there 1 day, 2 days, or 3 days, I work with them to get all your clinicals, all your information, and make sure I have your Medicare card insurance, your Social Security, so we can run eligibility and see how we can quickly bring you to healthcare. So one of the first things that I very need from every resident that is in the hospital, I need to make sure I have their insurance card. I would contact your family members, the case manager to check to see if you have your insurance card in your wallet, or if finance could give me a copy of it just to run the eligibility. That's the first step to make sure that you can come to healthcare. Make sure we have a copy of your insurance card. The second one is I'll be contacting the case manager throughout the weeks to get any updated clinicals so they can review our clinicals and see what we need to get everything ready for your room, so when you're discharged from the hospital. I also need to get rooms ready. When we get the rooms ready, I work with Jerome, and he goes around, make sure all the rooms have beds, they have TVs, everything that you need. I work with Jerome to get those rooms ready. After that, I make sure I call the case manager and I give them MOT. MOT is the mode of transportation. It's how we're gonna transport you back from the hospital or rehab back to the ARC. And I make sure I give all that information to them. So when you come for a respite stay in healthcare, I would need your doctor's name, a list of medication, and if you have a DNR, I would need a copy of your DNR. For skilled stays, I would need clinicals from the case manager. Faye would review those clinicals, and she would let me know, hey, this patient is ready for us to accept. I will contact the case manager again and tell her we're ready to accept, so whenever you're ready to discharge the resident from the hospital, I'll give them all that information. For, long-term care, I would also need your medication list. I need the name of your doctors, social security, if you have any HMP, which is your history from any doctors, anything you have from clinicals, we would need that too. So Faye can make sure she has everything for your history with your doctors. I can call Enrique up here, he's gonna talk about the medication.
Good morning, and I'm Enrique de Luna, I'm the Assistant Director of Nurses. I've been in long-term care for about, since 1982. And I graduated from Glendale College in California. Worked there in several settings, and as an Assistant Director of Nurses, infection control preventionist, nursing assistant instructor, and other things. In 2006, we moved to Texas, over here to San Antonio. And of course, I had to ensure I had a job. So I was hired in a facility, CCRC facility, Morningside Ministries. And then I worked there for 17 years as the Assistant Director of Nurses and the same thing, staff developer. And then for 11 years, I worked as a Assistant Living Director. Moving to the ARC, it was in 2022. And I'm supporting our Director of Nurses, Faye. I also do the infection control preventionist and the nursing assistant instructor. I'm gonna talk to you about medications, how that works when we have a new resident. And for our residents that come in skill, meaning that they are going to receive therapy, Part A, the medications are inclusive on there. You don't have to pay anything. It's already inclusive. However, there is a little things we do go over when Diana sends we send the clinicals to us. I review what medications you will be on to make sure that are available for you when you arrive. There is some of them that are some exceptions. Exceptions will be some medications that are specialty medications, maybe cancer medications, some other medications that the pharmacy will not be able to provide on time for you. So those we can discuss those on an individual basis. On the private pay or respite, that'll be your pharmacy of preference. If you have HEB, Walgreens, or you get your bottles, actually, you wanna bring your bottles from the doctor, they have to come on a blister pack or a bottle, an original bottle, please. They cannot be in the little pill boxes. That would not be appropriate because we need to actually, our regulations, as our Director of Nursing has said, are very strict, and we need to know what you're getting. We actually identify the medication that the staff is giving you. BAMC medications that we have a lot of residents, a lot of you do have BAMC. We do our BAMC medications refills. We send them over every week. We review them. We start on Friday. On Monday morning, we do get a list from the staff. I go ahead and electronically approve it to be sent over to. We send it over to BAMC via electronic, and then on Mondays in the afternoon before I leave, I take them over to the front desk to be delivered on Tuesday morning to BAMC, the BAMC pharmacy. Once they get it ready for us and fill it up. And on Friday, we get that in the morning on Friday. So we only have one delivery, unfortunately, that's we have there. So after the Friday, we get what we go over the list and see what they have sent us. Now there is some medications that are not, that BAMC does not cover. You probably know that, the over-the-counter medications. Some of them they will, like Tylenol, ferrous sulfate, iron pills, those are covered, but there are other ones that are not covered. So not all the medications come from BAMC, unfortunately, so then we have to have a backup. Once we don't have the backup, we have to call it to our pharmacy, which is Pharmerica. We do get our refills from Pharmerica as our primary pharmacy. We are also regulated to making sure that if we get an order from the doctor, that we have to start the next dose of medication, meaning that if we have let's see, an order for an antibiotic, we have to get it from our emergency kit, give it to you from our pharmacy, so it might be a charge for that, okay? There are just routine medications, BAMC will send them over to you. If it is too soon or there is some kind of delay on what they have on the stock, they also will tell us that, so there might be a charge. Well, we have to call you to let you know that happened. The staff will call you to make you aware. Do you have any questions on medications? Yes?
How does it work if you get your prescriptions from Randolph?
If you get your prescriptions from Randolph, usually they come over from BAMC here, not Randolph, and I believe we can also, I'm not really sure. We can send them over electronically, but someone has to go pick them up.
Like someone like who?
The person.
I'm being admitted, and yet I gotta go get my pills.
That's a good question. I'm not really sure. We have not found that out. However, if you
What was
are
the
being
question?
admitted under Medicare, remember, if you are a Medicare recipient, skill, you're admitted to us, all the medications are covered. The facility will pay for it because it's in the same bundle that you get.
We get those medications from Pharmerica. When
Mhm.
you're skilled, everything's ordered from Pharmerica.
And who are they?
Yeah, no, we don't.
We,
use
we,
our-
our facility,
Walmart, Repsol.
if you are respite or short stay, yeah, they will be delivered. Actually, HEB, Walgreens delivers them. But the thing is that if there's a medication that is to be, or is scheduled to be given for the next dose, we need to get it soon. So we have to order it from Pharmerica. A 5 days, yeah, a 3-day supply, a 3 to 7 day supply needs to be ordered to make sure that you don't go without it.
Are they physically around? I never heard of them.
Pharmerica, no, it is, we actually is local, but it is, it's national, yes.
It's not covered by Medicare.
It-
The cost,
Well, if you're not Medicare, you're coming over rehab, it is covered. The facility pays for the whole thing, including medications. The only medication that do not cover is the specialty medications. In that, well, a case by case, we can talk about that, because if you have it at home, that you're taking a specialty medication, you can bring it over, of course, in the original bottle. But if you are you're private or respite, or you're long-term care resident, or a resident long-term, then it might be by BAMC, or it might be if you would choose to have the medications brought by HEB or Walgreens. That's good. However, if there's a medication the doctor orders, like say right now we give him an order for Tylenol, and it's not there, we don't have it on hand, we have to give you that medication on the dose or the time that it is scheduled to be given. So therefore, we have to order a 3-day supply or a 7-day supply from Pharmerica. And unfortunately, it has to be a charge to you, if it's private or BAMC, long-term. But if you're skilled, not, you will be covered, 100%. Yes, sir.
2 questions. One, what is the interaction with Express Scripts?
Oh, well, it's the same thing. When we do electronically send over the request for medications for our long-term care residents or our BAMC or respite, we can also order it to Express Scripts. Yeah, they deliver.
The other question, a word that I haven't heard, maybe because it's separate. Often the dismissal from the hospital is to rehab, especially from orthopedic surgery and related things. If the rehabilitation is separate, then is a 3 midnight stay going to be in that link between rehab and facilities here? Is there a special pathway there?
You have to have, the 3 midnight stay is when you're originally sent to the hospital. If you go from, is that what you mean, from hospital you go to rehab specialty, like PAM specialty? Is that what you're saying?
Yeah, you break your hip, now you need rehab, and you're in rehab. Is rehab here at the ARC, or is rehab a separate facility, as my wife went through, and then would come to the ARC?
It depends. It depends on what, we prefer you to come straight to us, because we have the rehab here.
Okay, thank you.
Yes, but we require 3 midnights at the hospital. Or Medicare, not we. Medicare would require that 3 midnights for them to provide coverage.
Then I'm gonna extend the question. The civilian hospitals particularly are are under their pressure to dismiss within the first 15 seconds.
I know.
Hospitalization. What is your experience with the pathway there? Is there an interaction with the administration at the other hospital? What's that issue?
What
To get to
usually-
the 3 midnights?
Yes, what usually happens is the case manager will contact us and yes, you're right, they wanna discharge you as soon as possible. And we try to say, okay, is there any other condition that you may be able to keep him for another night? Or what I want to also say is they cannot discharge you unless you consent. It's up to you. Yes.
If you decide to be discharged prior to the 3 days, then it might be a private pay, yes. You can come over still to healthcare, but under private care, if you do not have the 3 midnights. But it's a choice you have. You don't want to be at the hospital, of course, that's a choice. Then there might be that you don't require to be there, and you may not need to be on rehab if they're telling you that. But most of the times is we review, FAA reviews our clinicals to ensure that what is you are coming to us, what is it that you're being referred to us, and then we can provide the care to as well, because we need to make sure that we have the means to provide the care for you that you require.
Two things. You will take prescriptions out of bottles that are original labels. They come to you. In other words, if your spouse or someone is in care, can you bring in their prescriptions?
Yes, definitely. In original bottles, always in original bottles. If you have and if sometimes we get mixed pills in there, we cannot accept them. And it is because of safety. As we don't want to make sure that we don't give you some other medication.
All meds are covered, correct?
On hospice, not all medications are covered. They only cover whatever you are you were admitted on hospice. What is the diagnosis you were admitted for hospice? Those are the medications. Particularly, the ones that particularly are covered are the pain medications. Yes, those are most of the times, maybe 99% of the times they're covered. But other medications, we have to ask them for a list. Whatever they do not send, then the rest we send it over to BAMC to be filled, if you have that. Though, needless to say that we will need your military ID to send over, because every single time we have to send that, every single time we send for a refill to BAMC, we need to send a copy of your military ID with the order.
So you can get things like this from BAMC, even though you're not a patient.
Yes, that's correct. Even if you're not a patient, yeah, you can get those if you're long-term care.
Hello, I am Deborah. I'm the social worker in healthcare. I have been a social worker for about 10 years. I graduated from Our Lady of the Lake in 2014, and I've been doing long-term care the entire time since I got out of school. I've been married for 35 years. My husband retired from the Marine Corps, so I'm very familiar with military life and things like that. Working here at the ARC is a privilege, and I appreciate that very much. Everyone here is so friendly and accommodating. It's awesome to share this, to be able to share working with the team and to be here at the ARC. My duties as the social worker in healthcare really cover just about anything that can come up on any certain day. What I consider to be one of the biggest parts of my job is to be the patient advocate while they're in healthcare. I will come and meet with you as when you arrive, shortly after you arrive. And I know one of the first questions that's always asked when I speak to the patient is, how long am I going to be here? And to be honest with you, at that point in our conversation, I don't know yet. When you come into healthcare, there is a very lengthy process that happens. You're admitted into healthcare once you've done all of the admission part, and then you're going to be assessed by the interdisciplinary team. That includes therapy, that includes nursing, that includes dietary, that's myself for social services. You're going to speak to the activities coordinator. There's going to be a whole bunch of people coming in and out of the room, asking you a lot of questions, trying to understand why you're there, how we can accommodate your needs while you're with us. So it's exhausting. The first few days are exhausting because therapy comes in, they do their assessment, and then you're going to start doing therapy with them. And we're still all going to be coming in to get information from you. And Faye touched upon it for all of the assessments that we're required to do. We're on a time frame. Medicare drives everything that we do, and we have to visit with you by a certain time. We have to do our assessments by a certain time. And then Diana will also be the person calling either you, speaking with you, or your family member to set up that first initial care plan meeting. We try to do that within the first week that you come into healthcare. There's a lot of questions that you have. So we try to meet with you within that first week, and all of us will be there, the whole team will be there. And we discuss, your assessments, your initial assessments and how those went. You discuss preferences, meal preferences with Arlie. That's important. Nursing will discuss all of the issues that you have going on with them. And then at that point, we're gonna start to talk about what your plan is for discharge, what that looks like for you, where you want to go. If you're an independent living resident, coming back to independent living. Sometimes changes are happening at this time where you are changing your living situation. We're going to talk about assisted living, if that's an option. And then if that is the route that you're going to take, we start planning that. Which assisted living are you going to? Lakeside, Crestway. We talk about the managers there coming in to do an assessment, because there is an assessment that needs to be done if you're going to be choosing one of those assisted livings. So we start to discuss what your options are. I know that, even staying in long-term care, even staying in healthcare is an option. So if that is an option, there are things that we start to do to process that discharge. Because when you come into healthcare, you're going to come in typically on a Medicare stay. You've had some medical emergency, you've gone to the hospital, and you require therapy to come back to your independent living situation. So we're going to start talking with you as early as when you get there about what your discharge plan is when you're ready to go home. And let me just say, when you're a long-term care resident, we have care plan meetings with the resident and the family every 3 months. And it's a little bit different if you're there with us for a Medicare stay. Like I said, we try to meet with you within the first week to discuss your plan, your discharge plan, and what needs to happen while you're there. We can meet with you anytime. You just need to find me or find any member of our team, and we can schedule a care plan meeting with you to have a discussion about where you're at in therapy, how things are going. Anything that you might want to discuss with us, that is available to you at any time that you're in healthcare. When you're a Medicare patient, we try to meet with you every couple of weeks, depending on how long you're going to be there. to give you a continual information about how you're doing, how you're progressing. We're discussing the discharge plan. What does that look like for you when you're getting ready to go home? And it can change. You know, I know that a lot of residents come in and they think they're gonna go back home. And then we realize that over a period of weeks, there is little to no progression, and so a different plan has to be made. Now we're looking into an assisted living situation. So we have to start that process, maybe working with the managers, get that assessment done. And even that can change. Maybe you're not appropriate for assisted living. So then we have to change gears again, because now we have to stay in healthcare as opposed to coming back. So it's very fluid. It's constantly changing with the therapy and how the progress is made. So we're trying to keep you as updated as possible. And I know that John, we have weekly meetings, we have morning meetings every day, but we have weekly meetings with therapy and the therapist so that we can discuss each patient. We discuss what progress they're making, what difficulties they're having. We're discussing, you know, we know what the discharge plan is at that point, and, you know, if we feel like that's appropriate for them or not appropriate. So all of these discussions are happening while you're in healthcare, while you're receiving therapy, while you're getting your nursing care. And John will ultimately, the director of rehab, he will ultimately let us know, so-and-so has met their therapy goals, and now it's time for us to discuss them going home or planning their discharge. So at that point, we'll hold another meeting with you and your family. We'll discuss where you're at in the process, how therapy has gone, what progress you've made. We want to clarify the discharge plan, and then that's when you start working with me specifically to plan your discharge home. That could include ordering home health for you if you're coming into independent living. Some residents want home health as an option. They want to have the nurse that goes into their home to check on them weekly, and they get to do OT and PT in their home. A lot of residents prefer the outpatient therapy, where that's at the gym upstairs. So it really just depends on, you know, personal preference as to what arrangements are made for you at that time. A lot of, John will hold a home assessment right before that care plan is done. And during that home assessment, you're gonna go into your own home, you're gonna go with the therapist, you're gonna do the daily routine that you normally do, walking around your house, going to the restroom, getting in and out of the shower. All of these things are going to be evaluated at that time. And that's at the point where they realize that you may need grab bars put into the shower, or, you know, bars around the restroom or in the shower, you know, like a toilet riser or things like that. So that's at the time when work orders are put into maintenance, to have those things done before you actually get home. So all of this planning takes place. We have the care plan meeting. I'm, you know, ordering home health, maybe giving an order for outpatient therapy, any DME, any equipment that you might need, walkers, wheelchairs. All of this stuff is discussed, and all of these things, orders are done before you leave. Oxygen orders, hospital beds. Those get a little tricky with Medicare, and you have to have the right diagnosis, and it takes a little bit of time. But all of those things I try to get all of those processes done before you leave, so that everything is done at home. When you get there, everything is done. We hope that the maintenance has done the work for the work orders that you need. The equipment has been ordered, home health has been referred to. Whatever referral that you need, it is my job to make sure that those things are put in place before you leave the facility. And anything that might come up after that. Do y'all have any questions for me? Oh, one of the things that I wanted to mention, and it was briefly mentioned earlier, but when you come into healthcare, one of the things that I just want to make clear is that our facility, gratefully, is almost full. We have a lot of Medicare residents right now. We have a lot of long-term care residents right now. So when you come into Medicare, I want to mention that you're more than likely going to share a room. We have very, very few rooms available, very few beds available. And I know that there are some patients, some residents that want a private room. And we work really hard to work with you and try to accommodate that, but it's not always done. We're not always able to do it. And there are things that we have to take into consideration. We have to have rooms available for patients who need isolation. We have to have, it's a numbers game, and we're always moving things around and moving pieces and things like that. So we try to accommodate your request for a private room when we can. It's not always possible. I did want to mention that more than likely you're going to have a roommate. until a room becomes available if you're desiring a private room. Just wanted to mention, yes.
Is there a microphone?
Oh,
I'm losing my voice.
that's okay.
Thank you. On the private room, I noticed, and perhaps Cordy can address this, on the occupancy report, I believe it said in healthcare, skilled nursing, that it was 77%, empty. Why is it that some people that want private rooms cannot get it if you're only 77% open?
So we are licensed for 91 beds. So right now, and we have rooms in the Oaks, but what happens is we have long-term residents that are private paying for a whole room. So they pay for the bed that they're in and they pay for the other side of the room as well. That's what brings down our numbers for availability, because our long-term residents, and many of them have private rooms. So, and they've been there for years and it's just not available for us to use. So that's where the difference in our rate, in the room numbers go. What we're licensed for is completely different than what is available, because the residents have the option to have a private room.
In rehab, do you, so you're saying though, if they come out of the hospital, what you're saying then, if people come out of the hospital to rehab, probably they would have to share a room?
Correct. Yes.
Thank you.
Yeah, if it comes up, I just don't want that to be a surprise for anyone, that when you come to us from a hospital, the chances are very high that you're going to have a roommate. Just because we don't have a lot of complete rooms available for private situations. We can maybe work that out, depending, a lot of people moving in, moving out, different things are happening. Like I said, we have a lot of moving parts, but you initially will probably come into the facility with a roommate. Yes.
I understand that you have a physician that works with you. How does that interact with the physician that you may or may not have on the outside?
Okay, so, yes, we have our medical director, Dr. Soria, that sees the majority of our patients at the facility. But if you do have a doctor that you've had for quite some time and you really want to stay with that doctor, we just have to do a little bit of a vetting process to make sure that, we have their license, their insurance, and that they can meet our documentation requirements and our visit requirements. So as long as we can, work with them individually to make sure we can meet that on case by case, you could, continue with your physician. But a lot of times Dr. Soria will cover folks while they're here in healthcare, and then you go out, say, for appointments with specialists and kind of coordinate the care together. Does that make sense? Okay. Any other questions? I guess we're at question and answer time now, so. Yes, ma'am, we have a lady in the front. Erin, appreciate Erin's help with this.
Okay, my question is, I want to see Dr. Soria, and he says, you can't go home, but you don't need to go into the hospital. I want you to go into healthcare. What do I do then?
Okay, so I'm sorry. So he says that you cannot go home.
But I don't need to go to the hospital, but I need some skilled nursing care.
But you need skilled nursing care. Faye, do you want to talk about that? Because
It's probably gonna depend on why he's saying that. He usually calls me and we'll discuss why. And is it an acute change of your condition? Maybe exacerbation of your COPD or CHF heart failure or whatnot. So it's an individual basis. It depends on what's going on. Usually he'll call me and we'll discuss, what's best for you. Because this is his recommendation, and I would always question, why do you recommend that? That's, if you're coming straight from home and you're coming to us, that would be private pay. Yes, because it is not, you don't have the qualifying stay from the hospital. For weeks, like I said, it could be It depends on the situation. Are you gonna get better? Is that an acute change? Is this your, normal now? You're not gonna get better as far as your functional. Is it not safe for you to go back home? Those are the things that we discuss, basically, It's not safe to go back home, so it's safer for you to stay in long-term, but there's no acute change that qualifies you to go to the hospital. You see? So that will be considered as long-term? You'll be long-term with us. You have to pay private, yes ma'am. So when there is an acute change in your condition, in your chronic conditions, an exacerbation of any chronic conditions that you have, it's best to go to the hospital and have a workup, They have good diagnostics there and see what's going on with you, and then you could come to us after 3 midnights and covered by Medicare. Do the rehab and hopefully get back to your living independently. Yes, ma'am.
Medicare, will cover home health care. I mean, if you can speak with your doctor, and they order home health care rather than going to it's covered by Medicare.
Yes, you're talking about your home after the rehab. That would be Deborah. She sets it up like home health.
Right, or you could go through your doctor and set up.
Yes.
Yeah. Okay. Another thing, I wanted to say that, I don't know if people are aware of it, but that 3 midnight stay, watch how it's billed and how when you get the rejection, see whether Medicare has reviewed it. Because I ended up going to Medicare fraud site and was saved $5,000 of billing. They had not bothered to bill Medicare. The hospital just decided, our patient planning committee has decided Medicare won't cover it, so we're not billing Medicare and we're billing you. So there is a lady, and she was wonderful. She helped me with this because it was considered illegal. They never billed Medicare. They never did bill TRICARE. They just billed me. So watch out.
That was the hospital.
And he was in the hospital just 2 nights.
Would you please address using long-term care insurance?
It's a good question, yes. I know that Diana helps us out with that, and she probably wants to talk a little bit about how that process works, but that is something very important. If you have long-term care insurance, yes, it is a benefit that will help reduce your costs for long-term care. Diana, do you want to talk a little bit about what you do for that?
So I just recently started helping out with the long-term care, and Ricky is training me to do the long-term care, so.
And actually, on long-term, what qualifies you for long-term care insurance is mostly that you'll be in skilled and long-term care nursing facility or assisted living. Most of the insurances, long-term care insurances cover that. That if you're needing some assistance with some of the 6 activities of daily living. If you, it also depends on the insurance. And you may qualify with only 3 of those that you require assistance with. Do you know the activities of daily living? What they are? Okay, toileting, dressing, bathing, bathing is showering. Grooming, grooming. So some of those, they have to be like 6. Some of them kind of have 6 of them. Eating, yes, eating is another one. If you require assistance for at least 3 of those, you may qualify. But the thing is that you need to call the insurance and let them know that you're planning to be admitted to a long-term care facility, either assisted living or a skilled nursing facility. Then they will open the claim and they will send over the letter to us or to you, and they just bring it over to Diana. Diana, we will fill out the information, just enter information and we'll send it back to the insurance. And they will send us another form filling out what it is actually what you require, what kind of assistance you require. And then it goes there, and then sometimes goes back and forth, several times, several weeks, sometimes months, unfortunately. But you get retroactive too as well. You get retroactive coverage. I mean, but you have to actually be admitted already on the facility that you're planning to be at.
Yeah, but you have to have the insurance in place, you can't just call an insurance company when you think you're going into long-term care. It's gotta be in place before that.
Oh, of course, you have to have the long-term care insurance in place, of course, and most of us, like, most of it will be like, Genworth, Genheca. GE. Yeah, it's a lot of different types of insurance, long-term care insurances. And you have one of those, if you require that assistance, it's good to take care of it, I mean, take advantage of those, if you can. But it needs to start from you guys and see that, okay, I'm planning to be admitted to assisted living or nursing, I need some nursing care, and I'm going to be there. So the day that you are admitted, that actually can call the insurance that you are admitted there and you wanted to use your benefit.
I have a question. Oh,
Yes.
it's not about long-term care. If there was a continuation question, was there? Mine's different.
Okay.
Mine has to do with the 3 midnights. If you go into the emergency room, and quite often in emergency rooms, there won't be a bed right away to put you into the regular hospital. And you spend the night in the area of the emergency room. Is that considered a one of the 3-night stays?
A lot of times it's what they call observation. So again, our team they help to scrutinize that and make sure that you have had the 3 midnights. So you're right, sometimes they'll hold you there for observation.
And that's not considered one of the 3 nights?
Right.
That's what I thought. Thank you.
Right, we have to make sure we have authorization, so we make sure to vet that and check it out before we do, so. Anybody else, questions? We have a lady over here in the red.
Speak to when the renovation is going to start for healthcare.
Yes, phase 2.
Does that affect the number of beds that will be available over time?
Yes, and I know phase 2 has been a huge subject. And like I mentioned with long-term care and healthcare, there are so many things to talk about. So for time's sake, I didn't go into that, but I know we're having separate meetings, many meetings, listening meetings to get your input. My understanding is that in January of 26 or so is when we're gonna be starting that project. And I know that the goal is to look at about 6 rooms at a time. There are gonna be small sections of the facility at a time that will be worked on to make sure that we're still accommodating residents with their care with the least amount of interruption so that we can keep a flow to your day. But yes, we're looking at that in 26 for phase 2 renovation.
My question was for Diana, on weekends, let's say I'm in the hospital, I've been in 3 nights, and it's a Friday, and I have to get into healthcare. What is the procedure on weekends?
So I have an admissions phone, I have it on me 24/7. Anytime I'll get a call, but I usually get a list of residents in the hospital every day, and I check that list and I'll make sure I contact that case manager since the day that you arrive. And I make sure I get all the clinicals that we need for Faye to review. But I always have an admissions line phone number that you can call. Any case manager could call me at any time and I'll be ready to answer that phone call.
This is back to long-term care again. I'm curious, it sounds like, or the way I understand it, the patient, whoever the long-term care patient is, has to handle the business part of that the park doesn't do that. I mean, you don't bill the long-term care insurance.
So the way that I've been working with long-term care, when a patient tells me that they have their insurance and they initiate the claim. When they initiate the claim, they let me know. I call the company and I let them know, yes, this patient is in our facility, and I give them the day that you were admitted to our facility, and I work with finance. They give me the statements and I send them over to the insurance, and that's how you get reimbursed.
And do they reimburse you? They don't reimburse this facility?
Yes, I believe they reimburse you, and then you decide if you want it reimbursed to the ARC, to your house account.
Okay, but what if, you know, the person is demented and has no relatives? I mean, how are they going to start a claim and do that paperwork dance?
Yeah.
Generally, that's where you guys can really help us a lot with pre-planning, right? We can't stress pre-planning enough. So in the event that you become incapacitated, you're not able to speak for yourself or your wishes, hopefully you've designated a healthcare power of attorney, someone that can speak on your behalf, right? If we don't have children, that we're looking to other relatives, a pastor, a neighbor, a friend, or working with resident services to help us to keep all your information as most up to date as possible. And that's everyone having a plan B. Who here knows the importance of having a plan B? Right. So that helps all of us help each other to make things more smooth for you.
Thank you.
You betcha. Anybody else? Okay, well, I know for sake of time, we wanted to stay on time, but we appreciate you all coming today. On the handouts that you have, if you have any questions, you have our key staff contact information. Don't hesitate to reach out through phone call, email. We will make sure to follow up and get back with you. We thank you all and have a wonderful morning.